Welcome to the Diabetes Podcast, where real stories meet real science, helping you take charge, not just take medicine. Today we're joined by physical therapist Dave Jeter from Spokane, Washington. Dave has 25 years of experience helping people understand and improve their musculoskeletal health. Think strength, mobility, balance, endurance, and yes, pain. But also how all those pieces work together. We'll dig into common pain myths, why imaging isn't always the answer, how the hip bone is the knee bone, and what physical therapy can do for people with diabetes, including frozen shoulder, slower healing, and neuropathy considerations. You'll also hear simple, actionable ideas to protect your joints, build balance, and keep your independence as you age. Plus, why flexibility and movement variety matter as much as strength. Let's go. Hello and welcome to the Diabetes Podcast. I'm Reggie.
And I'm Amber.
And Amber, today we are talking to Dave Jeter. He's a physical therapist out of Spokane, Washington. Dave, welcome to the podcast.
Glad to have you. Thank you.
And David, can you tell us more about what you do and maybe a better introduction, if you will?
Well, the reason why I do podcasts like this is because I feel like physical therapists do a terrible job of talking about what we do and why we do it and how we fit into musculoskeletal care in the healthcare industry. And I've been doing physical therapy for about 25 years now. And I'm just kind of running into a lot of people who don't really know why they're in my office. You know, they have pain, but they don't know whether or not physical therapy is a good place to start. And I want to tell them, yes, this is how you get your body moving properly and actually healthy, right? The difference between what is musculoskeletal health and what is just being pain-free. And those two things can be a mile apart. And I'm sure we'll get into some of that stuff.
We will. So I want to ask you, when you say musculoskeletal health, I think people within healthcare circles understand what that is, but from your mouth to our ears, what is musculoskeletal health to you?
Well, I think a lot of people, when they come in my office, they say, I have pain, therefore I'm not healthy from a musculoskeletal standpoint, which pain is definitely an important aspect of musculoskeletal health. But I'm looking at a more broad definition, things like range of motion, things like strength, things like endurance, things like balance and coordination and pain and function. Those are the kinds of things that I'm looking for, so that when someone comes into my office and they say, you know, maybe they're halfway done with their treatment, they say, oh man, my shoulder feels great. I don't have any more pain. I'm always asking them, okay, but how do you move? Do you move the way we want you to move? Are you strong the way we want you to be strong? Can you do the function that we want you to have, or you want to have, more importantly? Because, you know, we could sit in a recliner and not move at all and probably be mostly pain-free most of the time, but that's not musculoskeletal health.
I love that. I like it. So what does healthy tissue look like then? And how does it behave any differently from unhealthy tissue? How does somebody know?
Well, I kind of think about, when I think about that kind of question, I think about a really kind of 30,000-foot view when I think about what the body evolved to do over the past, say, 1.5 million years, right? We evolved to hunt and gather and walk and run and lift and push and pull all day long. That was what our bodies did.
Not sit all day.
Not sit all day
not be in front of the computer all day.
In front of a computer, exactly. And for the vast majority of human existence, the average lifespan was about 35, maybe 45 years old. An older person would be in their 60s, you know, for up until the past, say, a few hundred years. And so we're taking this machine that is built for half the time span that we're wanting to run it, and we are not doing things like yoga and balance exercises and strength exercises and endurance exercises the way that the body was meant to be used, again, from a hunter-gatherer sort of aspect. And we're kind of wondering, like, well, why do I have all this pain, or why do I have all this dysfunction, or why can't I, walk for more than 15 minutes? And it's like, well, because for a variety of reasons, but a lot of it has to do with we're not using the body the way it was meant to be used.
Okay. So a lot of times in my experience talking with people, people tend to get very focused on, oh, I've got bad knees or I've got low back pain. And there's this belief that it's this one section of the body. And if they just fix that one thing, if they found the secret to that, and you definitely, I have a different take on it, but your take on it, I would love to hear your perspective there.
Well, let's go with the example of bad knees, right? We have a saying in our organization, the hip bone is the knee bone. And it's sort of a silly little phrase, but people kind of think, oh, well, maybe my hip is part of this knee pain. And it's like, it's not just sort of kind of part of it. It is the reason for the knee pain, right? Your knee does one thing. It bends and it straightens. That's really all that it does, especially if you're standing up tall. When we look at the rest of the leg, there's a bunch of joints that do rotational movements and side-to-side movements that the knee doesn't do. But if those joints aren't doing their job or aren't stabilizing in that way, then it puts a lot of abnormal stress on the knee. And the knee says, hey, why are you asking me to do something that I don't do well, right? I can't do that. Why are you asking me to do that? And that's why the knee becomes painful. So when someone comes into my office, typically with knee pain, I am very much looking at how their lumbar spine moves, how their pelvis moves, how their hip moves, how their ankle moves, how their foot moves, because I know that the joints above and below that knee are directly, not kind of, sort of tangentially, but are directly responsible for that excess stress on the knee.
Mm-hmm. And how do you explain that to someone? Because I've heard before, I had knee pain and all they did was look at my hips, or all they did was, how do you address that with your patients that come in, that even though they're feeling pain here, that's probably not what, exactly what you just said. That's not the originator of the pain.
I think, well, sometimes it can be very difficult. I mean, it can be very, very challenging. Some people are not the kind of person that want to have a 15-minute discussion about biomechanics of the lower quarter. And I can appreciate that. Hopefully with that person, I can do some very simple mobilization of the hip and get them to feel their body. So a lot of times I'll have people show me a squat, show me how well you can just do a knee bend. And what I'll see is this kind of terrible looking squat where their knees are pushed out over their toes and they aren't using their hips. And, there's a lot of dysfunction in that squat. And then I can do a couple of mobilizations and get the person moving a little bit differently, and then ask them to move in a little bit of a different way. And they can show me a much more efficient movement that is less painful. And they can feel like, oh, when I move better, I feel better. And maybe there's something to this idea that if I get my leg moving, then the victim will stop complaining so much.
Okay. I'm going to shift just a little to something I also see happen a lot. And it has to do with pain, severe pain, and fear in movement with that pain.
Yeah.
And then also this idea of, I'm going to go get imaging, I'm going to get some cortisone injections, maybe I need surgery. Like, that's where a lot of people's thinking goes, I've noticed. How do you think that became the default mindset? And then what's the problem with that?
Well, with all due respect to my, let me step back just a little bit. Primary care physicians are very, very overwhelmed with what they are trying to do. And no one, as far as I know, has ever died of shoulder impingement. But lots and lots of people have things that they're going to their primary care physician. Their primary care physician is looking at them in terms of quite literally a life or death thing, i.e. diabetes, right? High blood pressure, cancer screens, all of those sorts of things. So when you come in with shoulder impingement, right, shoulder pain, the primary care physician, for the most part, is kind of saying, okay, this is not all that interesting to me because this is not a life or death sort of thing. and I'm not going to spend a lot of my time on this. I'm just going to let's get some pictures of it and send them off to somebody else to try to take care of this problem.
Mm-hmm.
And so people think that they need to have a picture of that joint to diagnose what is wrong with it. And I kind of like to say, physical exam for the win. Like if we can see how the person is moving, if we can see how their strength is, if we can tease out each of these structures in the shoulder and do special tests to stress them in certain ways, I can say with pretty decent accuracy that your shoulder is the painful structure. And inside your shoulder, either it is your rotator cuff, or it is your labrum, or it is your biceps tendon, whatever. But that painful structure lives in a neighborhood, right? That painful structure lives in a neighborhood. Now we need to look outside of that neighborhood to see why there is more stress on that structure. So the medical world is typically looking at a painful thing and saying, or trying to say, what is that painful thing? And then they kind of want to do something to that painful thing. And again, with all due respect to my surgical colleagues, the surgical colleagues want to go in and either tie something back together, or they want to clean out some irritated structures, for the most part. And that's not to say that surgery is not a important and valuable option for some people. But if you have, like, again, let's take that shoulder example, for instance. If you have this posture where your head is forward and your shoulders are rounded and your thoracic spine doesn't move well, when you try to take your arm overhead, all of those structures have to get out of the way for your shoulder to move properly. If you're stuck in that forward flex posture, and because of that stuckness, you end up tearing your rotator cuff because you loaded it in an awkward way. Yes, you can go in there and tie that structure back down to the bone such that the rotator cuff will be intact again. But if you haven't changed the neighborhood in which that structure lives, what is the likelihood that that structure is going to survive many, many years of function, right? We should start by improving what that neighborhood is doing in terms of movement and strength and stability and function, and then see what happens. Either that structure is going to calm down, or you might need that surgery, but at least you have improved the biomechanics of the whole upper quarter before you go into surgery and you become a good surgical candidate.
Yeah. And then I also see people who have surgery and do not do the required physical therapy post surgery.
I like to say that I steal a line from Mad Men, where everybody's looking for a spaceship, but what they really need is a time machine, right? Everybody's looking for a piece of technology to fix their problem, when in fact what they need is to go back in time when they could move better, or maybe they ate better, or maybe they had better habits, that sort of thing.
Mm-hmm. The parallels of what you're saying, like two completely different fields that you and I have, but the parallels are lockstep. The problems with the burden of the primary care physician, the fact that there are 2,000 people in that one physician's care, and it's going to be the bleeding neck problem that gets the attention, the majority of the attention that day, or the blood pressure that's 180 over 120, like that person is the priority.
Yes.
So,
and should be.
Yeah, right. Absolutely. Yeah. Okay. So for someone who's in pain right now, what are some of the biggest myths about pain that might lead them into the steps that you just pointed out?
Well, the first concept that we talk about in pain science is pain is not damage, right? Pain is not damage. Pain is an interpretation of your brain of the stimuli that is coming into it. And all pain is a product of your brain's interpretation of threat level. That's sort of a general kind of idea. So if your idea is that I need to be 100% pain-free 100% of the time, that's not realistic. And there's no way to be there if you're alive and you're not 20 years old, right?
Starts about 25.
Yeah, totally. So, so what I think when I think of maybe your folks in the diabetes realm, and maybe they are people who are trying to make a very large change in their life. Maybe they've come to you and you have given them a pathway forward in terms of a better relationship with food. And maybe you've said, hey, I'd like you to start moving a little bit more, and they start moving a little bit more and they start having some pain. I think the thing that you should really consider is going to a physical therapist and saying like, hey, I'm trying to make this life change. I'm starting down this road. I have a little bit of pain here and there. I'd like to improve my musculoskeletal health in terms of how I move, how my strength is, how my endurance is, how my function is. And that physical therapist should be able to identify places on you that aren't moving well and give you specific things to do and move you with manual techniques and get you over that hump, right? So it's always very interesting to me to have a patient that I'm kind of picturing in my mind of your folks who are very deconditioned, who haven't done exercise in decades and haven't really done anything. And they come to me for one specific thing. And let's say we get their knee feeling a little bit better, but then their opposite shoulder starts feeling a little bit sore, or their ankle starts feeling a little bit sore. And part of that is because if we're changing the system, right? If we're changing how the body is moving, we're now asking different parts of that body to do different things that it hasn't done in, say, since the Reagan years, right? So if it's not unusual for me, again, if I have someone who has cervical spine pain, neck pain, that they come to me 3 weeks later and says, man, my neck is feeling so much better. It's moving so much better, but between my shoulder blades and a little bit lower is really, really killing me. It's like, well, that's because that part of your thoracic spine has not moved well in a very long time. And now we just need to kind of keep moving down the line. So be aware that the painful structure that is popping up is painful because it lives in a neighborhood that is putting more stress on it. And so if that might just be a temporary thing that's going to go away over a couple of weeks. But if it doesn't go away over a couple of weeks, it's appropriate to go in and see someone about moving better and building up slowly too.
Okay. So I'm thinking about somebody who might have range of movement issues. They notice that they would like to be able to get their arm right up next to their ear, but they can only get it so far. I hear so many people tell me they can't put certain devices on their body because they can only reach their abdomen, or they can only reach certain areas. They can only give their shots in certain areas due to mobility. But unless you're in acute pain, I've noticed, and maybe I'm wrong, but I've noticed you can't get a physical therapy referral without some sort of issue to work on. Is that true, or could you get a referral just for mobility increase?
I think it would be from an insurance standpoint,
right?
From an insurance standpoint, a payer standpoint, if you had zero pain, again, I find that to be a really unusual scenario in which someone says, I have 100% no pain. But okay, let's do a different example, which I'm sure that you see is frozen shoulder, right? Because of course, patients with diabetes are commonly diagnosed with frozen shoulder or adhesive capsulitis, and quite often that is not painful at all. That can be a pain-free. I mean, it can just look like a brick wall in terms of like movement, but they don't have any pain. You can absolutely get a referral for that patient, even though they don't have pain, because they have lack of range of motion, they have lack of strength, they have plenty of musculoskeletal dysfunction that we can work with. So I think there are ways around it. Let's say this, if you go into your primary care physician and you say, my shoulder doesn't move well, I would like to improve my function. I would like to do physical therapy. I would say there are very, very, very few primary care physicians who are going to argue with physical therapy, right? I mean, they're trying to get
I would
people
hope
to
so.
come
Mhm.
rather than, say, no, you don't need that.
Mhm.
So I think that's and if you do run into that, then you can always go to physical therapy without a referral in any state in the United States and pay out of pocket, which again would be an unfortunate scenario that your physician would say no to physical therapy because for whatever reason.
Mhm.
Again, I think that's an unlikely scenario. If you go to your primary care physician and say, I want physical therapy instead of OxyContin or a cortisone injection or, God knows what else, they're going to say yes. Hopefully they will say yes.
And I think health savings accounts could absolutely be used if that were the case, to be able to do that. Okay. So at what stage would you say to someone, okay, we have exhausted the limits of physical therapy, or even if I think about my aunt, Richie's aunt, my aunt by marriage, who had a fall downstairs and was very immobile post that fall. And as crazy as it is, it wasn't recent. The ER physician told her bed rest for 8 weeks.
Wow.
I know. And we're all like, what? Excuse me. Is it, um, how, what would you have done if she went straight to you instead of the emergency room, which most people would go to the emergency room first, but just
Well, I mean, it's important for her to go to the emergency room to make sure there isn't
anything broken?
yes, absolutely. But I think that's also an important thing to recognize. Let's say if it's a less traumatic problem, right? Let's say it's a less traumatic problem. There are definitely health insurance plans that allow you to go to a physical therapist straight away, direct access, right? And there was a Kaiser Foundation study that was done. In California, physical therapists work in the primary care and urgent care settings, and they see the musculoskeletal issues that come into those
That
settings
sounds really
initially, right? Yeah. And what they found was that when a person sees a physical therapist first instead of a different kind of practitioner, they have 30% fewer visits than if the person was seen by a MD or a PA or a nurse practitioner. And part of the reason why is because physical therapists do that. We do this all day long. This is what we do all day, every day. And so we look at someone and we say, I do this not all the time, but I would actually say rarely. But a guy came in my office and I said, you're going to need surgery on his back. He came in and he looked like he was going to have back surgery because of the things that I found on physical exam, because of his history, because of the medical process that I went through to see what was appropriate for him. I said, we're gonna try some things. We're gonna do a couple of things, but I want you to immediately get in to see this other physician, and they're probably going to want to do some imaging because of what I saw, and it's hard to explain that, like, obviously in this particular context, but physical therapists are trained to see red flags. Physical therapists are trained to see when something is outside their scope of practice. And so I don't want to see somebody for a year with shoulder pain if they actually do need some sort of surgical intervention. But at the same time, I find it's a little bit too much on the other end of the scale, right? I get people who come in and they say to me on day one, they're saying, I just need to be here for 6 visits so that I can get my MRI. My insurance won't pay for my MRI without 6 visits of physical therapy. I just want to get my MRI so I can, quote unquote, see what's going on. And then I can figure out what to do. And it's like, well, that's not actually right. The right way to go about this is to do a proper and thorough physical examination to, quote unquote, see what's going on and see what the proper course of action is. That's not to say that you can't possibly miss anything with a physical exam. And it's not to say that imaging isn't valuable, but at the same time, imaging is not perfect as well. I've had, my father-in-law had 7 CT scans, including 2 with contrast, that missed bladder cancer when he had a history of bladder cancer times 2. And no one did an MRI until, 4 months later. And finally the MRI found extensive cancer within his pelvic region. And that's a tough story. It's a really sad story, but it's also just to say, like, this image is not a perfect thing. And it's not going to have this red arrow that says, oh, this is the problem. This is definitely the thing that's going on. I'll give you another example. You do not appear to be 20 years old.
Who are we talking about?
If you went in and said, my neck is painful, right? And they did an x-ray on your neck, I promise you have degenerative disc disease in your cervical spine, right? Because you are not 20 years old, and that is a normal thing for someone of your age group to have. Now, is that part of your pain? I don't know. You had that 3, 6, 8 months ago. If you had taken an x-ray at that time, it would have showed the same thing and you would have been pain-free. So,
right.
So whether or not these findings on imaging are correlated with the pain complaint that is current is not necessarily, those things are not well described, I guess. But if you have
that's so important. I think that's so important.
If you have a history, no, you're fine. Sorry. But if you have a history that says, I fell down and I heard this big pop and I can't move my arm in a certain way, and I have specific muscles that are very, very weak, and, yada, yada, yada. And then you say, wow, this looks like a rotator cuff tear. And then you have an MRI that shows a rotator cuff tear. Well, those things, all of those pieces kind of go together. But that still doesn't mean you should have surgery right away. You should get the whole body moving so that you can become a good surgical candidate, and that rotator cuff could heal, right? That can scar down and not be a problem. And it may not be totally intact, but you might have what I would consider musculoskeletal health, right? Range of motion, strength, function, pain, and endurance.
What are your thoughts on people who are doing pretty well, but then get an MRI, get something that shows there might be an issue, and then they kind of own that issue, and it changes their mindset about their health for the worse?
Yeah.
Can you talk about that a little?
Yeah, I don't know what to say. I'll give you a similar kind of example. I had a guy who was in his late 60s, and he came in and he said, my knee is bone on bone. Sent by the surgeon for some pre-surgical physical therapy, which is totally normal and great that he did. We really worked on making his knee move better, making his hip move better, making everything strong and whatnot. And he left saying, my knee is totally pain-free. I can go up and down stairs. I can do a full squat. I can walk for an hour. Everything's doing really well. And he left my office and he walked straight to the surgeon's office and had a total knee on a knee that was pain-free. And I just kind of thought to myself, I'm like, why would you put metal and plastic in a knee that was pain-free, kind of regardless of what it looks like on imaging, right? There's nobody who's going to argue that he doesn't have arthritis and he doesn't have, joint space narrowing and whatnot. But why someone would go through the process of a total knee and have the risk of having a bad outcome, where things get infected
and do happen. Even cardiovascular, in the space of diabetes, even cardiovascular concerns that can come up from such an operation that are very rare and wouldn't expect that they do happen.
For sure. Everybody thinks they're going to be on the right side of the bell curve, is what I like to say. Everybody thinks they're going to have this amazing outcome from surgery. And it's like, well, there's half of the people that are on the left side of the curve. And some of them are in that real short tail that is really, really terrible outcomes. And I'm not pretending that is a high likelihood, but it is a risk. And people don't think about risk in a realistic way, I think.
I agree. I think that's been proven in studies that people are really bad at assessing risk. When you think of the number of people afraid of plane flights versus driving.
Driving to the airport.
Easy example. That's more dangerous.
Well, or again, in your realm, I mean, eating the processed foods and the white refined sugars and all of that is a risky behavior. That is not without risk. And people don't put that into perspective. That's probably more dangerous than, the water slide that you won't go down.
Well said. Well said. So, one last thing. Let's talk about hip replacements for a second, if we can. Is it true that because we're living older, that at some point there's a high likelihood we'll need to get a new hip midway through? Like, what are your thoughts about that?
What do I think about that? I think that, again, we have this amazing technology in terms of medical science and, frankly, food science and all the other things that are making us live much, 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 much longer. And again, even healthy people who do a lot of the right things all of the time, their bodies are going to break down. And where that body breaks down is somewhat of a challenging thing to really understand. I like to sort of joke with my patients that if everyone did yoga from the age of 5 every day, then I probably wouldn't have a job at all. But at the same time, if everybody did yoga at the age of 5, we would probably just be seeing older and older people, because when you're 80, you're probably not going to be able to do headstands and, the real fancy stuff. You're going to slow down and your body's going to break down. So I don't know if it's inevitable that any one particular thing is going to be in need of a total joint, but obviously hips are quite normal for people to get, and frankly, of all the total joints, hips tend to do better than most, with the exception of if they dislocate. That's the one problem, is that sometimes they can dislocate a little bit, but they are typically a lot less painful than total knees, which are quite painful.
So Dave, I hear a lot of endorsements for yoga.
Yeah.
Which to me sounds like we could all be doing a better job of, I guess, probably first off, just awareness of what normal range of movement around a shoulder, around a hip, around an ankle, all of that kind of stuff. There is a great deal of information, and has been for a long time, on how to make muscles bigger. But there isn't so much information, or at least not so much talk, around how to make, tendon better. There's more elastic, all of these kind of things. Is there some general recommendations that you just see is missing in the general population?
Yeah. So this is what I say. So I always love it when people in, say, right around the age of 60 come into my office, when they, again, a very typical person where they have low back pain, and I get them moving a little bit and they feel a little bit better. And then we start to do some strengthening and their function gets better. And, right around that 6 to 8 week mark, I've really built up a nice relationship with them. They're moving much better. They are feeling much better. And now I've kind of got them a little bit in my sights to say, okay, now is the time, right? Now is the time for you to make a real change in your musculoskeletal health. And we start talking about range of motion, strength, balance, endurance, And range of motion, I mean flexibility. So my guys, like if a guy like you came into my office right now, I would assume like if you said, yes, I go to the gym 5 days a week and I do my thing, I would say a guy like you typically is going to be doing a bunch of lifting and a little bit of cardio and no flexibility at all. And all I want you to do is I want you to take a little bit of that lifting time and I want you to transition it to flexibility. And, but for some patients, maybe endurance is their thing. Or if that 60-year-old patient, I start really talking about balance, because balance is the thing that is going to keep them safe and independent over the long period of time. And I start talking to them about this concept of, if you go and you do a program, and it doesn't really matter what that program is, as long as it has all of those components, and you work really, really hard at it for 10 years, you're not going to see massive gains, right? But what you're going to see is 10 years later is your peers falling off of a cliff in terms of function, and you are going to be staying relatively stable in terms of your function, right? And so it's really hard. It's really hard to talk people into that, because you're going to put all this effort in and you're not really going to see any gains. That's a really challenging sales pitch. But at the same time, I think there's definitely enough people that recognize, okay, my body's moving better. If I can layer on a little bit more endurance, a little bit more balance to this situation, I'm going to be able to stay independent in my home for another 10 years. And that makes a lot of difference to people.
So when you say working on the mobility, working on the balance, what's a good recommendation for per day, per week, whether it's a session? How long should the sessions be? That kind of, can you get a little bit more into the weeds?
Yeah.
And what's missing from even, like you said, guys like me, what's missing from the daily routine that we can add to help make sure that I'm not in my 60s and taking a dive or going off a curb wrong, and well, there goes my training for the next however long.
Well, I think obviously it's going to be different for different stages of life. For you personally, right? I would say flexibility is going to be a really important driver of your musculoskeletal health. Endurance is going to be an important piece of like how much function you're going to be able to do for higher level activities. Again, strength is probably important, but I don't think strength, again, for a guy like you, is probably all that important if you have some of the other aspects, because you're going to be doing daily activities that are going to keep you moving. But as people get older, I want to see them do more balance. And if you're in that, I don't know, 70s to 80s, maybe half of your routine has to do with balance, because that is the most critical aspect of your musculoskeletal health. So I guess my thing is it changes over time. What your emphasis is going to be somewhat based on what your activity level is and what you want to do, but also the stage of life that you're in. So I can't really say specifically what any one person should do. I mean, I can say what any one person should do, but I can't say what everyone should do. But I think the other piece is that it doesn't matter what you do, right? If you want to take a Tai Chi class, if you want to take a kickboxing class, if you want to do water aerobics, if you want to run, if you want to row, it doesn't, like, none of any of it matters specifically about what you're doing. And there is no magic bullet in terms of exercise or the perfect exercise. The perfect exercise is something that you enjoy doing, that you can get the aspects of the exercise, the benefit of those aspects of the exercise, and you can continue on with it, right? If it's just a drudgery, then that's probably not the right answer.
Mm-hmm. Dave, regarding that, I love to run and I love to row. But when I row, there's travel time to and from the lake that's built in, which is why running often gets done more often. But with that, I'm self-proclaimed horrible at warm up and cool down, other than the fact that you've got to carry your boat to the water and go get your oars. And so all that's like walking kind of stuff. But for someone like me, what would you recommend as a like non-negotiable to keep um, flexibility and all of that up? Because I mean, we'll go have a hard workout on the water and then just get out of the boat creakily, like you're jumping off a trampoline, and then
Yeah.
put the boat up and drive home, sit for 30 minutes. So it doesn't strike me as probably the best thing that I'm doing. So give me your take on that, please.
I think obviously warm up is really important. But what's funny about that is there is no good studies on injury reduction with certain warm-ups. So that's really kind of an interesting thing. Anecdotally, we all know that if it's a cold day and you've been sitting in your car and you haven't done anything, and you go out into that rowboat and you start to try to do 1,000 yards as fast as you can, that's the
And we
time
don't do that, Dave.
Yeah, but I guess what I'm saying is there's no evidence. As far as I know, there's no research that says this is how much you should warm up and this is what you should do. I think for me, it's okay to do what you're doing in terms of rowing, even as you're doing it. But you've got to commit maybe to another day of a flexibility day where you're doing an hour of flexibility, kin stretch of whatever that flexibility looks like, so that you are getting the opposite of that sitting posture, right? We all are losing to gravity. We're all losing the war to gravity. And so we've got to get chest opened up and shoulders back and head over shoulders and hips behind us and to the sides and rotation and all of those different things. So if you can commit a day to flexibility, sometimes people think, I feel like sometimes people think that they are not doing, that's not a workout, right? Flexibility isn't a workout. And I think to myself, well, it depends on what you're looking for. If you're looking for the beach bod, you're right. Flexibility is not a workout. But if you're looking for musculoskeletal health, then the flexibility is absolutely a workout. And similarly, balance training a lot of times is not, it's not maybe going to get your heart rate up very much, and you're not going to necessarily get sore like you're really working your muscles for strength or whatnot. But man, we could all use a lot more balance. All of those Bosu balls and the eyes closed, all of the different types of balance exercises that people could be doing. And it doesn't have to be a one day a week kind of thing where it's strength, flexibility, endurance, and balance. But maybe the last 5 minutes of your strength day, you get on that Bosu ball and you try to just balance on that with eyes closed or whatever is appropriate for you to do. So again, the idea of the warm up and the cool down are probably important aspects of a workout, but I don't think you should beat yourself up about not doing enough on that particular day, as long as you're keeping your body moving properly, maybe on other days.
I love that. And especially, and I did once go to physical therapy with a rowing type injury, and I was doing yoga at the time, but his feedback was I wasn't doing enough open because it's all this way. I wasn't doing enough the opposite, like as you said. So it's awesome. And I think also, if we talk about cause of death for females, we're talking about a broken hip in older age a lot of times. And it's the activities of daily living, which is being able to toilet by yourself. No one wants to have to ask someone to help them go to the restroom or get up to do those things that they need to do. So can you speak some to the importance of balance and proprioception and in maintaining your activity levels, so that, because we always say, like, it's not if you fall, it's when. It's about getting all that together to help prevent falls, but also if you do fall, you roll with it better, so to speak.
Yeah. That starts to make me think about like NFL players, when they can take those hits, those just like amazing, just the amazing forces that are involved with doing that. And granted, I recognize that they're getting injured and they're playing with pain and whatnot.
And they're younger.
And they're younger. Yes. Like if I happen to catch a ball over the middle and get tackled by one of those folks, I just can't imagine myself doing anything other than lying in the fetal position for quite some time.
Same.
But when we start talking about older folks and we start talking about function and balance, and that's where it really has to be a balanced program of endurance, of flexibility, of balance, and of strength. And again, when we start talking about osteoporosis, we're talking about weight bearing exercises. So a lot of people like to talk about doing cool stuff in terms of water aerobics, which can be great for the heart and it can be great for movement. And it is not a bad exercise by any stretch of the imagination, but it's not going to help as much with osteoporosis prevention as weight bearing exercises as well. So I think that family members, right? If you're the son or daughter of a person who is getting into that age bracket, you can see them kind of slowing down. It's really appropriate to go to a physical therapist and say, this is where this person is at. What can we do? What does the program look like to get this person moving better, to get them stronger, to get their balance going and get their endurance up? And what can we do to get all four of those aspects in line?
Okay, this one you might not can answer because it's a doozy.
All right.
What if that older family member refuses to go because of whatever reason they can think up in their head? I mean, you're not going to convince anyone of anything. What could you maybe
talking about
do?
my mom? Are you talking about my mom?
Or my grandmother, or, yes. The list goes on. Yeah. Not to call anyone out.
I guess we all get to make all the choices, right? We all get to make all the choices, and all of those choices, the accumulation of all of your choices is what your life is. And there's only probably 20% of Americans that do really any exercise at all. So you're talking about the vast majority of people right now. It's hard in my world because, again, the vast majority of people coming in haven't done any exercise in decades. And just getting them to move a little bit can be a big challenge and can be a big hurdle. I would like to believe that when people have some success, right? When they get moving a little bit better, they start feeling a little bit better, they start walking. And part of my job too is really pointing that stuff out. How far are you able to walk today? Well, we're out, I was able to go to the store for 20 minutes. Okay. Well, remember on day one, you could barely walk around inside the house, right? That's a big deal.
Yeah.
And being encouraging, but, and I don't know what you do for the person who just kind of refuses to go, besides if you can maybe set some sort of goal or some sort of thing that the person wants to do. Hey, if you want to go, you say you want to go up to, I don't know, some fair or something. I don't know, whatever the person wants to do.
You want to do something with your grandkids. Yeah.
Yes. You want to go to the soccer game, right? You want to go to the soccer game, but the soccer game's on the other side of the field. You're going to have to walk 20 minutes to get to where the soccer field is over uneven ground, right? Which your walker isn't going to work well on. You're going to need to improve your balance and your endurance and your function to be able to do that kind of stuff. So, I mean, if you can bring it back to function, if you can bring it back to what somebody actually wants to do, then I think they're more likely to at least start. And if you can get them to start and they can start feeling a little bit better, it's part of our physical therapist's job is to really point out, hey, remember how you weren't able to go upstairs without, really pulling on that rail, and now you can go upstairs without anything, and now you can balance on one leg for 5 seconds. And maybe some people say, well, I don't care. I never needed to balance on my one leg for 5 seconds before. It's like, well, you actually did. You just don't know that you need to do that.
Yeah, getting people to know what they don't know, or understand things they don't think that they need to understand, is probably one of the most challenging.
I
So it
think one
sounds
of the
like you.
I think one
Sorry,
of
I
the
was going to
hardest
say.
things, that I can see in your profession
Mhm.
is that eating good food, I imagine it does make you feel better, right? As opposed to eating really terrible food, but not that much better, right? I don't think, compared to, again, like being in pain in terms of low back pain and then moving better, and you're like, wow, I don't have any pain. That is a very dramatic and drastic change, I guess it seems like it's more subtle. It would
Well,
be hard for people to understand.
yeah, we just say, hey, hop in the car. We're going to go get a milkshake and then drop them off at physical therapy.
There you go. There you go.
Don't recommend that. Maybe not that. Okay.
Not if you like your physical therapist.
Right. Not how to win friends and influence people. I see. Okay. So tell me, talking about people who have diabetes, what differences do you notice in terms of healing, feeling, recovery when somebody has diabetes versus pre-diabetes and other things?
Well, I've certainly seen a lot of adhesive capsulitis shoulder, frozen shoulder that is really, really challenging with diabetes. And so if you're noticing that your range of motion in your shoulders is dramatically reduced, I would say be very aware of that. That's one thing. Again, just pure healing time. I know it's going to take longer, especially if someone is post-surgical. I know that it's going to take just longer to heal. And a lot of people, it's always interesting to me when I have somebody who's had a total knee and they're 2 months out from their total knee, and the incision's healed and whatnot, but their knee is still quite painful. I just don't understand why it's so painful still. Say, well, why don't you YouTube total knee arthroplasty and watch what that surgery looks like? And I think you'll have a better idea of why your knee still feels the way it is. Because again, there's just a tremendous amount of healing that has to take place. In terms of diabetes and physical therapy, like specifically besides healing time, besides some extensibility, I think there's maybe some evidence to suggest that because blood sugar is high, that creates a little bit of stickiness between some proteins that can cause some fascial layers to maybe not move well on each other. I don't get too much into that, but I think that's at least an explanation for why sometimes people have decreased range of motion, which again sort of comes back to why, if you have diabetes, it is crucial that you are doing flexibility. Flexibility is very, very important. So I can imagine that if you go to your primary care physician or another practitioner and you're talking about diabetes and you're talking about exercise, they're going to be thinking about cardiovascular, right? Because obviously that is an incredibly important aspect of the exercise program. But there's the other things are very important.
Mhm. Is there any special recommendations you have for someone who has pretty severe neuropathy?
Ooh, as far as I know, I don't believe that there is any reversal of peripheral neuropathy once you have the stocking glove sort of distribution aspect. So I think anecdotally, I think that if a person really does a good cardiovascular exercise routine, that some of that can be mitigated. And I don't, again, I don't have any research to back that up. What I do know is when you start talking about the lasers and you start talking about all the other spaceships that are out there that are supposed to, the technology, the technological cure for that kind of stuff, as far as I know, none of that is terribly valuable. And I think that's a really important thing, so that people, I mean, even again, I know this is apples and oranges, but even when people come in and are like, should I buy a pillow for my neck? And I'm like, well, I don't know. I mean, like I just hate people buying things so much that I even hesitate to say a special pillow for their neck is the right answer. It's like, is your pillow comfortable? Okay, use that one. If not, then try a different one, see if it's a little bit comfortable. But in terms of peripheral neuropathy, there's some, I don't know, the vibration plates. There's no good answer there.
Mm-hmm. Mm-hmm. Yeah, I don't believe that. I could be wrong because I pay more attention to the nutrition and exercise diet, but I don't believe the American Diabetes Association or the Association of Clinical Endocrinologists, they have any kind of recommendation towards that. And if there was something with really strong clinical benefit, it would be in their
it seems like it would
recommendations.
pop up. Yes.
Mm-hmm.
Yeah.
Yeah. Awesome. So I know we're getting close to time. If let's see, let's do something kind of quick. This is just like top of your head, first thing you think of.
Okay.
So what's the most overrated treatment people chase first?
Massage.
And just really quickly, why?
Because it feels good. And there's nothing wrong with that, right? There's nothing wrong with getting a massage on a semi-regular basis. And there's nothing wrong with good myofascial work. Again, I'm not just poo-pooing it, but at the same time, I have so many people that I've seen for one thing, I've seen for their knee, and then I end up seeing them for their neck, and they've had this neck problem thing going for 6 months, and they've been going to the massage therapist for 3 months. And I'm like, why did you start there, right? As opposed to a more comprehensive program. I think people want a passive solution quite often, right? They want somebody to do something to them to fix their problem. And I think
the massage doesn't have any homework assigned to it.
That's the thing. Yes. I mean, if you are a good massage therapist, hopefully you're doing some stretches that are going to facilitate some of the fascial release stuff that you're doing. But that is my my beef is people want to just have this problem fixed without doing any of the work that is necessary.
Well, I think we're all to some degree guilty of that. So,
sure.
Yeah. Most underrated habit for staying independent after age 60?
Balance.
Biggest mistake weekend warriors make?
Thinking they're 20. But again, there's such a weird balance there because, you can go out and tear your ACL skiing, and that can be a tough thing if you're my age, 35. I'm just kidding.
Thanks.
We'll say 35. But the consequences of not going out and skiing are, I think, much greater than the risk of some of that stuff. So yeah, you're going to go out there and there's risk involved, and you may end up with a musculoskeletal injury that requires some sort of treatment. But the risk of not going out and not doing those things, I think, is much greater. Frankly, I think there's more people sitting home and watching football than doing than crashing their mountain bike and breaking their clavicle.
Well said. Okay. One thing that you wish every 30-year-old or younger started doing now?
Running. I think.
What about the knees?
I'm so glad you said
advocate.
I'm so glad you said that, because there was an amazing longitudinal study that they wanted to say that runners had osteoarthritis or more osteoarthritis. And what they found was runners had less osteoarthritis than non-runners. And it was dosage dependent, meaning that the more you run, the less osteoarthritis you have, which is not, that is not causation, right? Running doesn't prevent osteoarthritis, but clearly running more does not create more osteoarthritis. So if if you are literally sitting on the couch and you do need to do something like a couch to 5K program, you do need to do some flexibility work, you do need to do some other things. But when you can get your body moving properly and keep it moving properly, and the endurance factor of running, like there is nothing better for a person than being able to run 3 to 5 miles.
I love that. Okay. Awesome. So how do people learn more? How do they find you? How do they get in touch with you if they want to follow up on this or get more information?
I have 4 clinics in the greater Spokane area. accelerationphysicaltherapy.com is our website. I have a Facebook page called Start with PT, which is just sort of some of my musings. I work with a lot of students from Eastern Washington University, and sometimes when we have conversations, I have really good conversations with my young people that always challenge me a lot, which I very much appreciate. I'll write a summary of maybe some of that discussion on Start with PT, because I think just talking about some philosophy can be really helpful.
I agree. Yeah. And I love that you're giving back to younger people not much younger, just slightly younger people learning about physical therapy.
Well,
and helping others.
It's my favorite part of my day, to get students going and have them be successful and have patients appreciate what they're doing. And that's what physical therapy is all about. It's all about having somebody come in and feel like they can't get anywhere, feel like they can't do anything, and being able to really change not only their musculoskeletal health, but then that turns into changing their whole life, where they start playing with their grandkids, which is, that's why we do it.
That's very significant. And it's a huge carrot to get people to do something different. I love that. Thank you so much for coming on, Dave. We appreciated having you. Is there anything else you want to share before we wrap it up?
No, I really appreciate you letting me come on and talk a little bit about physical therapy.
We loved having you. Thank you.
Yeah, thanks for your time. A big thank you to Dave Jeter for such a helpful conversation. Remember, pain isn't always damage. Start with a good physical exam before chasing images, and train the whole neighborhood, not just the one painful spot. And don't forget the fundamentals: mobility, strength, endurance, and balance, especially balance after 60. Small, consistent work now preserves independence later. If you're dealing with shoulder stiffness, knee pain, or mobility limits with diabetes, consider seeing a physical therapist to build a plan that fits your goals. You can find Dave and his clinics at accelerationphysicaltherapy.com and follow his writing on Facebook at Start with PT. If you enjoyed this episode, please take the time to like it and give it a review. This really helps to promote and sustain this free podcast and get the word out to the millions of people worldwide that are struggling with type 2 and prediabetes, letting them know that remission is possible if you take action today. And if you have additional questions or need additional support, reach out to us at support@empowerdiabetes.com. Until next time, take courage. You can do this, and we can help.